exciting times in cancer care and in oncology, and I think also times where there's, as I see it, a little bit of tension because we have what we call precision or personalized medicine, where we're really able to customize the therapy and the treatment in many cases to particular patients' needs. But at the same time, that comes with cost and high cost of providing cancer care, which people are concerned about. So I was wondering if you might talk about this concept of precision medicine or personalized cancer treatment and how you see that balance between the possibilities but also the economic realities of providing this care.
Sure. Well, I think that the term precision medicine it really evolved out of something that we used to use a lot more, and that was personalized medicine or personalized cancer care. And then it was really in President Obama's State of the Union address where he adopted the term precision. That was the first time that personalized was transitioned over to that, and at least picked up widely. Certainly people have talked about it. But what it really means is exactly what you stated. So a lot of the therapies historically we've had have been either surgical approaches, and it's almost a one-size-fits-all. You have a tumor, you resect it. A drug approach where one drug is going to treat all of the individuals with this type of breast cancer. And the precision part of it is that we now recognize that, for example, breast cancer, we've all known that for years and years, there are different types. There's breast cancer that occur in generally older women that tend to be very responsive to manipulations of the hormone system, blockage of something called estrogen receptors, and tumors that don't respond to that. So that's kind of the early approach. Now we've got many, many more targets and differences. So breast cancer is no longer this hormone sensitive or resistant, but there are probably 15 or 20 different types. We see this in lung cancer in particular, and that's the one that people have been most excited about. I think if anybody watches broadcast TV, they inevitably have seen advertisements for some of the new agents out there. And those agents are drugs that are very, very selective for certain subclasses of patients with lung cancers and other types of cancers. And the challenge, as you said, is they tend to be pretty effective, some more so than others. But because these drugs are very, very, they take a lot of resources to develop and actually prove that they're safe and get them out into the consumer, to physicians and consumers, but they only apply to relatively small numbers of patients. The cost of them just goes up. The hope is that they're going to be so effective that the economic loss that patient has in terms of needing to go on permanent disability, not being able to work, and everything that goes along with that from a larger conceptual standpoint in terms of how much it costs society to care for that patient. It's going to be less expensive to pay for these very expensive interventions because that person will be able to contribute longer and do what we all do.
Yeah, so great. How does this, I imagine there's an impact as well on both the training of clinicians, sort of in this new era to think about how to know exactly what the right treatment is for a patient. Maybe that's simple in some cases because there's a test or a biomarker or something that indicates that. But I imagine there's a little bit of art and a science combined. And so maybe your thoughts on sort of existing clinicians who have grown up now and they have these tools available to them, how that's changed really the way they have to practice medicine in thinking about customizing treatment to patients and challenges of managing the clinical staff, but also training future clinicians too.
Well, it's already been hard. So, medical school compared to when I went to it and went through it to now has evolved enormously. And I think the days as an educator to teach students, this is what you need to know and this is how you do it are long gone. The name of the game is this is how you learn new things because there's just constant ongoing learning that we have. And we see this in all of our accrediting bodies. So for our, what we need to do to kind of, practice our specialty is we don't need it, but it recognizes that we do it at the absolute top level is board certification. And these board certification exams used to be you were board certified for life. Now you're board certified for a limited number of years, and you've got to go back and demonstrate that you've kept up with things. And so it's the keeping up with things that have really changed what we do. So and in the oncology world, I would say we're at the forefront of new therapies. Last year, we were averaging about a new drug or with a new indication. So a drug, either a new drug or an existing drug with a new indication, we were actually averaging somewhere around 1 or 2 a week, which makes it, and it's awfully hard to kind of keep track of all of that because it changes so quickly. And if you misuse that drug, well, it's only $4,000 a prescription for it, and maybe you shouldn't have given it. So the stakes are incredibly high, and it's changed how we do things.